Classification of asthma. Asthma severity is classified into four categories based on symptom frequency, lung function, and impact on daily activities. This classification guides treatment decision and management strategy. Intermittent, first is the intermittent. Symptom occurs less than twice weekly with minimal impact on activities. Nocturnal awakening occur less than twice monthly. Lung function shows forced expiratory volume in 1 second more than 80% predicted with less than 20% variability. Peak expiratory flow remain consistently above 80% of personal brace. Treatment typically involve short-acting beta agonist, that is SABA, as needed only. No daily controller medication required. Patients generally have normal quality of life between episodes and excellent prognosis with proper management and medication. Second is a mild persistent. The symptoms appears more than twice a week but not daily. Nocturnal symptoms occurs 3 to 4 times monthly. Exuberation may affect daily activity and exercise tolerance. Lung function test shows FEV1, that is the forced expiratory volume, more or equal to 80% and predicted with 20 to 30% variability. Treatment recommendation include low dose inhaled corticosteroid, that is ICS, as first line therapy, or leukotriene receptor antagonist, that is LTRA, as alternative. Regular follow-up every 3 to 6 month advice. Patient may experience occasional activity limitation during exuberation. Moderate persistent daily symptoms with exuberation that affect activity with sleep quality. Nocturnal symptoms occurs more than once weekly. Rescue inhaler use is required daily. Lung function shows FEV1, that is the forced expiratory volume in 1 second, 60 to 80% predicted with 30% variability, more than 30% variability. Peak expiratory flow typically 6 to 80% of personal best. Treatment include medium dose inhaler corticosteroid ICS plus long acting beta agonist LABA. Alternative combinations may include ICS with leukotriene receptor antagonist or theophylline. Consider referral to asthma specialist. Regular monitoring every 3 months recommended. Patients experience noticeably activity limitation and reduce quality of life during exuberation, that is during the acute attack. Now let's talk about the severe condition or severe type. Persistent continuous daytime symptom with frequent severe exuberation. Nocturnal symptom occurs frequently or nightly. Physical activities are significantly limited Lung function shows FEV1 force expiratory volume less than 60% predicted with more than 30% variability. Peak expiratory flow less than 60% of the personal best with high diurnal variation. Treatment require high dose of inhaled corticosteroid, that ICS, plus long-acting beta agonist LABA. Additional controller often necessary include long-acting muscarinic antagonist, that is LAMA, leukotriene modifier, and theophylline. Oral corticosteroid OCS may be required for a control. Biologic therapy, anti-IgE, anti-IL-5, anti-IL-4 or 13 should be considered based on inflammatory phenotype and biomarkers. Specialist management is essential with monitoring every 1 to 2 months. Patient experience significant quality of life impairment with frequent healthcare utilization and hospitalization risk. Classification may change over time with treatment and should be regularly reassessed. Stepping up or down, treatment should be considered based on symptom control, lung function, and expiration frequency. In all categories, management should include patient education, trigger avoidance, and a return asthma plan. Thank you.